slide. Okay. Too many. Okay. Thank you very much, Ida. The idea is to give you some insight on the interaction between bronchiectasis and asthma. I'll try to give you the panorama of the research in bronchiectasis and asthma we have that it clearly increased in the last 5 years. Looking to pathophysiology, it's clear that bronchiectasis recognize the problem of dilation of a bronchi that can start during the childhood with maybe some disease like TB or protracted bacterial bronchitis that leads to irreversible dilation of the bronchi. Certainly we have the problem related to inflammation, the problem related to chronic infection, lung destruction, and certainly everything seems to start with mucor hypersecretion, ciliary dysfunction, and epithelial dysfunction. This is a vortex that previously was defined as the vicious circle, but nowadays we understand that the problem is that the interaction is in different ways. It's not just a circle, but everything interacts in between the different problem that you can experience in bronchiectasis. So when you look to bronchiectasis, certainly underlying disorders are quite important. And we know very well that COPD and asthma are part of the game in bronchiectasis in terms of comorbidities. But also we have some interesting disease like ABPA. It is another interesting pattern of asthma, if you want, in terms of response of the airways. And certainly everything should be faced with looking to radiology, microbiology, trying to have clinical phenotypes, endotypes related to types of inflammation. And I will touch a little bit about inflammation, because I think it's important if we think to asthma in bronchiectasis. We think to bronchiectasis as a neutrophilic disease, but it's not the case. One of the main questions when you ask to the patient, what do you want to know about your disease? The first answer the patient said, I want to know what causes my bronchiectasis. So the correct diagnosis is quite important, not only for bronchiectasis, but you must know what are the comorbidities related to bronchiectasis, and certainly asthma is one of this. And certainly we go for, when you go for diagnostic testing for bronchiectasis, certainly you must have a CT scan for sure, because the diagnosis depends on, rely on CT scan and symptoms, but certainly the lung function testing is important, not only spirometry, we need some more testing because we are pulmonologists or allergologists, we need to know better how the lung works. And then we can have some bundle for the diagnosis, including IgE for Aspergillus, eosinophilia, the nasal NO, and other possibility. And certainly genetics is also part of the game. When you look to bronchiectasis in Europe, these are the data published last year of the EMBARC registry that collected about 20,000 patients with bronchiectasis around Europe. The level of asthma is here, in this cake is here. That means that about from 15 to 20% of patients has also asthma. And if you look to what happened in the different countries, you can see that there is an heterogeneity in terms of diagnosis and the presence of comorbidities in bronchiectasis. Italy is here, and you can see that the number of asthmatics are here, so around 15%. As I said before, we think to bronchiectasis as a neutrophil disease, where inflammation is related to the influx of neutrophil in the airways. However, looking to what happened looking to the patient in the Embark registry, we have a different pattern of inflammatory response, so we can endotype the patient in a different way. Certainly, we have neutrophilic endotype, we have eosinophilic endotype. And I will show you that the situation is not so simple. We don't have just two groups, but we have at least four groups because of the different interaction of inflammation. And certainly, infection is a major driver of inflammation. And on the other side, inflammation is a major driver of chronic infection. So, it's a vicious vortex, as I said before. But if you look to the sputum of patients with bronchiectasis, you can have different sample, and you can find this red, asthma has been cancelled here, but red is asthma. And so in this kind of patient, you can select and see how the patient separate in terms of inflammation and proteinomics in this side. When you look to eosinophilic inflammation, it seems to be important because if you look to the mortality in different cohort of patients from the Embark study, again, the higher level of eosinophil is related with a higher mortality in patients with bronchiectasis. So there is a correlation of the eosinophilic inflammation. This doesn't mean that all these patients have asthma, but eosinophil play a role. And if you look to the prevalence in Europe, you can find that Italy has around 21% of patients with bronchiectasis and eosinophilic inflammation. And that is quite similar in the other countries. So around 20% of patients present an endotype, that we can say an endotype, including eosinophilic inflammation. What about ICS user? Well, if you look to the data of the Embark study, the first drug used in bronchiectasis is ICS. It is not what the guidelines said. It's quite different. But, the misdiagnosis of bronchiectasis related to COPD and asthma is quite important. So the patient comes from 3 years or even more of diagnosis of COPD or asthma, and then arrive to the diagnosis of bronchiectasis. So it brings with him or with her steroids. And inhaled steroids are related to an increased risk of NTM, an increased risk of Pseudomonas aeruginosa infection. So this is a quite important thing to know. This is a paper we just submitted to Thorax, and we hope to have it published in a few months. And look into the ICS effect, and it's clearly that there is some effect, particularly in patients with bronchiectasis and asthma. And the same is, if you look to the role of eosinophil, when you have raised eosinophil and you have been treated with ICS, you reduce exacerbation frequency, hospitalization frequency, and also there is a signal about mortality. So when used in the right patient, ICS works. So the problem is that we use ICS in raised eosinophil or normal eosinophil, we don't have any effect. So this is another study we are now working on for preparing the paper. Is a collaboration study from the Embark Bridge. almost 200 patients from United Kingdom, Milan, and Barcelona. United Kingdom means Dundee, Scotland. And we looked to inflammatory markers, both in serum and sputum. And we tried to cluster this patient in different clusters, and we found 4 clusters related to these inflammatory markers that include interleukin-5 as a marker of eosinophilic inflammation. And you can see that this cluster were very well defined, and we have neutrophilic inflammation, a mixed neutrophilic and T2 inflammation, what I said before. Eosinophilic doesn't mean asthma, but there is a correlation. Then we have a T2 inflammation, cluster 4, and cluster 1 is a pouchy inflammatory response. And when you look to microbiome, we have a lecture of Gianni a few minutes ago, and clearly we have difference in terms of a different cluster, in terms of a microbiome, and this is related both on phylum and genus level. And what is clear is that if we look to the 4 clusters, there are 2 clusters where you have a mixed neutrophilic and T2 inflammation, or you have a neutrophilic inflammation. The exacerbation rate is higher, and the severe exacerbation rate is higher. So having T2 inflammation is related with exacerbation. So, and if you look to the different microbiome and the exacerbation risk and the presence of Pseudomonas aeruginosa around, again, there is an interaction between the microbiome, the presence of Pseudomonas, and the kind of response or inflammatory response. So it's very clear that it's not an easy task to say that microbiome run the exacerbation or inflammation run the exacerbation. Probably it's a mix of effects. What about bronchiectasis and asthma? So the panorama that brings to this study is that there is a cluster of patients with T2 inflammation. There is a cluster of patients with high level of eosinophil. There is a cluster of patients where eosinophil seems to be associated, particularly at high level of eosinophil above 300, that is related to exacerbation, severe exacerbation, and hospitalization. However, when you look to the EMBARK, so the 20,000 patient enrolled in EMBARK, clearly there is a difference in terms of bacteria. Haemophilus influenzae is related to asthma. And we know since many years that Haemophilus influenzae is related with asthma. And what is that the asthma has a better quality of life compared to non-asthmatics, and the severity score is better. However, if you look to exacerbation, when you have asthma, you have an increasing number of exacerbation. And when you use ICS and you have asthma, you have a protection. So making the diagnosis in bronchiectasis patient of asthma is important because you can treat the patient with the 2 diseases, improving the quality of life, improving the outcome of this patient. So the presence of asthma in patients with bronchiectasis is associated with less severe disease, but increased number of exacerbation, and ICS use in the correct patient reduce the risk. So this is very important. So when you look to your patient with bronchiectasis, you have to search for asthma because the use of ICS should be confined, I must say, to this kind of patient. But you can look the coin from the other side. So severe asthmatics and bronchiectasis. How many patients with severe asthmatic are related with bronchiectasis? And if you look to the SANI data, the Italian network for severe asthma run by Walter Canonica, it's clear that in about 16% of patients, 10% of patients who have asthma, and if you look to the what mean to have in severe asthma bronchiectasis, it means that you have a worse FEV1, you have a higher number of exacerbation, you have a higher number of patients treated with oral steroids for a longer time. So at the end of the day, what we can say that bronchiectasis is a common comorbidity in severe asthma, that severe asthmatic with bronchiectasis has a worse asthma control and is associated with worse lung function and increased exacerbation rate. So at the end of the day, this study confirmed the data looking to the other side of the coin. So clearly is important to treat correctly this kind of patient. What about biologics? If you have severe asthma and bronchiectasis, did biologics do something? Yes, they do. This is a case series, few patients, but now we are starting a large study under the umbrella of EMBARK, looking to different biologics. And in any case, in this limited sample size, in any case, there is a signal that you reduce the exacerbation, you can reduce dyspnea, you can improve the quality of life, and you can reduce the number of eosinophils as expected, and also the quantity of sputum. So having asthma as a comorbidity and treating correctly this kind of patient, you can improve your patient life. Let's go to ABPR. ABPR is another interesting disease where, bronchiectasis can be involved. And clearly we know that it's a complex disease, and certainly we can have Aspergillus, but also other bacteria, other fungi. And the importance is that we have a treatment. So we had to look for in our patient about with bronchiectasis, about ABPR. And if so, how important are ABPR in bronchiectasis patient? Well, if you look to the 70,000 patients from EMBARK registry, we look to the number, and the number is not so high, it's 2.8. If you remember, the guidelines said that in the diagnostic bundle, you must look for ABPR. Because this is run by UK data, where this incidence is quite higher. In Milano, now we don't look in all the patients for ABPR because it's a cost. Not all the laboratory do the work for looking for a specific IgE, a specific IgG for Aspergillus. Is always very complex for the patient. So we decided to look at ABPR only if there is a risk or a suspicions. But if you were in India, or you have a patient coming from India with bronchiectasis, well, there the testing was very low, but they report a higher incidence of ABPR compared to Europe. And this is for Professor Virchow, is a slide for him about treatable traits. I put it for him. And but again, here we put diagnosis as the first point. So clearly, investigating underlying etiology is important. And then you can see if the patient has frequent exacerbations, severe symptoms, and go for different approach, including macrolide, are clearly important, both in asthma and bronchiectasis. So there are papers looking to the effect of macrolide in severe asthma and in asthma and in bronchiectasis. And in both the sets, the macrolide works very well, reducing exacerbation by 40%. The problem with macrolide is that there is a macrolide. So you have resistance, you have hearing losses, you have gastrointestinal disturbances, you have a lot of problem, possibly the problem of NTM. So I think that the main problem is the approach. When you look to a complex disease as bronchiectasis, and you include another complex disease as asthma, and you try to understand what is the best approach to this patient, having bronchiectasis and asthma, you're clearly to have an evidence-based diagnosis. So please make the diagnosis. It is very important because it means that you can change your treatment, you can change the natural history of a disease. If you find asthma in a bronchiectasis patient, you have to use ICS, you can change the life of your patient without impacting mainly on bronchiectasis, but impacting on a comorbidity like asthma. Certainly, cluster analysis help us to understand better the endotype of our patient, look into eosinophil, look into neutrophil, mixed kind of inflammation, and you can work on this when you treat your patient. And clearly, when we look to how to manage our patient, clearly we have to rely now in the next future to new methods like microbiome identification, proteomics, and metabolomics, and many other things that can help us to subgroup the patient and try to make the better diagnosis. It's not just treatable traits, it's to make the best diagnosis for our patient. And taking into account that phenotype and endotype can be difficult because a single phenotype can demonstrate multiple endotypes, and a single endotype can be presented with multiple phenotypes. So don't rely on a single problem and a single diagnostic testing, but look to the patient and try to have the update approach to the diagnosis. And this is my last slide. And I think our patient is like a Rubik's cube. And you have to consider that this Rubik's cube change from the stable state to the exacerbation state. And you have to look to the many faces of the cube to try to have the patient treated at the best of our knowledge. So with this, I thank you very much for your attention.